I'm going to talk, I only have 10 minutes, so I'm going to tell you everything there is to know about multiparametric MRI and prostate cancer. Okay, so why is MRI important at all? Prostate cancer remains controversial. Even in 2021, the negative public pressure about early detection is not going to go away despite our trials. And so the increased use of novel technology is absolutely mandatory by us as urologists to decrease the biopsy rates. I think we all realize there's an increasing sense that prostate cancer is a spectrum of disease. Not all prostate cancer has to be treated. And the treatment of high-risk disease is going to be better personalized due to advanced imaging and molecular medicine, but advanced imaging like MRI. So to start off with, what is multiparametric MRI? Simply put, it's the 3 different phases: diffusion weighted, T2, and contrast enhanced. As long as your MRI has those 3 things, it's a multiparametric MRI. And so general rules of thumb, a 3T magnet is better than a 1.5T magnet. The endorectal coil, thank goodness, is no longer absolutely required. Our patients are thankful for that it's equivocal whether you need to use it or not. And generally speaking, MR spectroscopy is not widely used. Now, what is biparametric? This is actually becoming a debate in radiology. If you omit the dynamic contrast enhanced phase, that's biparametric MRI, and it is non-inferior in several trials. So I'm speaking about multiparametric, but I throw that in there because we do have patients who can't get contrast due to allergy or renal function, and so this is an option for some patients as well. These are just some images, I think, highlighting what perhaps MRI is most useful for: pre-biopsy, which is those anterior lesions, which we wouldn't normally biopsy if anterior is not part of your template. So I'm going to speak a little bit about MRI in detection, surveillance, staging, and recurrence. So in detection, before initial biopsy, certainly before repeat. In active surveillance, how often, and can we substitute it for a repeat biopsy? I think this is well established in pretreatment staging and operative planning and radiation planning. And then in prostate cancer recurrence, when do we use this? What PSA? Can we do this instead of the anastomotic biopsy? And then lastly, a little bit about novel imaging, because that's the exciting part of all of this. So are there alternatives to immediate biopsy? Certainly, these are non-MRI tests, blood and urine-based markers, that can improve specificity. And what can be very exciting is to integrate these with MRI. And this is just one article about different ways to sequence a common marker 4K score with MRI, whether you have access to an MRI initially or if you only have access to a marker initially, with the ultimate goal being to try to avoid unnecessary biopsy. So this is an example of one article where using 4K plus MRI tried to avoid unnecessary biopsies and maximally diagnosed high-risk patients. This is a list of the MRI targeted biopsy trials, and I put this up because NCCN recommends MRI before our first biopsy, but in Virginia I've found that it's very difficult to get insurance to approve this. These are the most common trials, and these are the things I reference when I'm trying to do a peer-to-peer. Intellectually, this tells us that MRI is superior in terms of sensitivity for high-grade disease compared to just transrectal ultrasound. And we can avoid unnecessary biopsy in 1/4 to 1/3 of patients, which is a big deal. Now, if we only do MRI-targeted biopsy, though, we miss somewhere between 5 to 10% of clinically significant prostate cancer. The last 2 trials, TRIO and PRECISE, just demonstrate that the combination of template plus targeted biopsies gives you the most information, finds the most prostate cancer. And I'm going to delve into that just a little bit deeper. This is one study that compared the diagnosis by fusion and by systematic of high grade and low grade. And you can see fusion finds more high grade, which is what we want to find. That systematic finds more low grade. And so that seems great. So why do we do systematic biopsy at all? Well, this is why. I'm sorry that's cut off a little bit at the top. If you sample only the MRI regions of interest, you are going to miss clinically significant prostate cancer 14% of the time in this European urology trial. But in the bigger trials that I showed you before, and I'm going to reference these again, anywhere from 5 to 10%, generally speaking, will be missed. And I just stress this because it is important to know that a negative MRI is not a guarantee that a patient doesn't have prostate cancer. It may indicate they don't have high-risk prostate cancer, but we are going to miss it that 5 to 10% of the time. And so keep in mind that the MRI is only as good as the equipment as well as the person who's reading it. So this is MRI fusion, just a good picture to look at. And of course, I think this is widespread now. It creates a 3D image and then gives us a nice bullseye target in the MRI area of interest. But I put this up as a caution as well, because if the targets aren't drawn correctly, or if we don't line it up correctly in the office, you have a bullseye going right through the wrong area. So we have to, as urologists, still be very much engaged in the ultrasound part of this and make sure that we really are targeting what we think we're targeting. And interestingly, MRI fusion versus cognitive fusion in all trials actually does not show a significant difference. So whether we're doing it with cognitive fusion or the actual Euronav technology or the other companies, it doesn't actually make a difference. So going to NCCN, what I've summarized here is if you look at NCCN 21, where is MRI in all of this? And so it's recommended before the initial biopsy, which can be a hard sell to insurance, absolutely before confirmatory biopsy for active surveillance. Prior to second biopsy, again, insurance tends to cover this. And then for recurrence, especially if you don't have novel imaging like PSMA or Axumin PET. So kind of delving down into this, this is an early detection, so recommended again before first biopsy if you have it available. And then recommended based upon a variety of different pathology results ranging from cancer to intraductal, ASAP, high-grade PIN. All of those recommend an MRI before the next biopsy. Now we're going to talk a little bit about serial imaging during active surveillance. And again, this is going back to NCCN. Recommended in active surveillance no more than once every 12 months. And so I think I've found it's very difficult to get this approved. I think it's very useful, especially to be sure that we're not missing an anterior lesion that was missed on biopsy initially. And so in summary of active surveillance from a combination of guidelines, it's absolutely useful to help identify missed or anterior lesion. It's really hard to see those transition zone lesions well, though. My experience is that insurance is not going to pay for it more than once a year unless you have a really strong justification. Sometimes it can be useful in delaying the next biopsy after your confirmatory biopsy if there are no lesions to follow. I think when to stop active surveillance entirely based on MRI is controversial, meaning an MRI lesion is not diagnostic of pathologic progression. It's associated with, but it's not diagnostic of progression to grade group 2 or beyond. So recurrent prostate cancer and MRI. This is very useful for local recurrence, but I very rarely have seen something as clear as these pictures where you see a nodule at the bladder neck. It's often a lot more subtle than that, but MRI is very useful and indicated for evaluation of elevated PSA after prostatectomy. And I picked this up from one paper. It actually, surprisingly, at very low PSA levels, so 50% likelihood of finding a lesion on MRI at a PSA of around 0.2 to 0.4. So these are the levels that we want. And MRI is useful at these levels rather than doing an anastomotic biopsy, for example. And then lastly, novel imaging in the future. This is a PSMA PET MRI, which I think is hopefully going to be the future, and I know other talks are about this. This is a little movie that shows the fusion of the PSMA PET with an MRI, which gives us that really nice resolution of our prostate and all the data that we get from that, but also gives us a sense of lymph node identification. What I think is fascinating in this as well, certainly this patient is metastatic, but you can see the index lesion within the prostate on PSMA PET-MR, which is interesting to think about focal therapy in the future and the use of this technology in that regard. So prostate cancer in 2021 and the role of MRI, there are many different tools available to us. There are things before our first biopsy, there are blood and urine markers, and multiparametric MRI is in every single step along the way. So I think it is definitely here to stay. So in summary, there's a clear role for the multiparametric or potentially the biparametric MRI in the following situations: detection, whether it's initial or repeat biopsy, active surveillance, pre-treatment staging, and certainly recurrence even at very low PSA levels. And when the MR is fused with PET, I think that's when things get really interesting. Remember, 3T magnet is preferred. You don't need an endorectal coil. In patients who can't get contrast, there's evolving evidence about biparametric MRI, which I think is nice to know that patients can still have an MRI in these cases. I think one takeaway from this really is the risk of MRI targeted only biopsy is 5 to 10%. You will miss clinically significant prostate cancer with only MRI targeted. And then lastly, of course, the MRI accuracy and performance characteristics really depend on the equipment you're using and the experience of the radiologist. So thank you all for this opportunity. I really appreciate the chance to be here today.